The Senning Lecture is now a tradition in the Cardiac Surgery Society to have a talk dedicated to one of the pioneers of the cardiac surgery. And this year, I think that we had the great chance to have one of the followers of the big pioneers. Professor Mohr is one of the surgeons who did, I think, the most contribution to our technique, to our knowledge, and I think that is the person who probably had the best beginning in the relationship between cardiologists and cardiac surgeons. Besides that, he had the opportunity to lead a very interesting group of surgeons in Leipzig, where he did found a good terrain to develop new surgical techniques, and we now see that most of the people who work now in Germany and also abroad came from this institution. Professor Mohr started his medical career in Bonn, Berlin, and also in Sydney, as I read. So, and then in his again, he started to work first in Bonn, where he reached the position of chief resident. Then he was appointed professor of cardiovascular surgery in the University of Göttingen, and then was, in 1994, appointed professor at the University of Leipzig, and at the same time medical director of the Heart Center in Leipzig. And this combination has been probably one of the best thing that at that time in Germany has been achieved. I can consider Professor Mohr to be the one, after Professor Borst, that did really made a bridge between cardiology and cardiac surgery. One word to resume this is syntax, a very important study that has been promoted by Professor Mohr, and also the collaboration with the American Society, and we should not forget the Dallas-Leipzig meeting that takes place once in Dallas and one in Leipzig, and it's a best opportunity of exchange between cardiac surgery from both sides of the ocean. I think I shouldn't spend no more words about this great personality, and we are all very eager to hear what he has to tell us today. Professor Mohr, please.
Thank you, Professor Ciclari, De Francesco. Professor Zenoni, thank you very much for the invitation to give this very prestigious lecture. I was very, very honored, and I thought a little bit, how can you address a legacy, and how can you put your personality and what you know behind such a big man? So we thought about what do we have in common, and what is the need for all of us, what we need to do. Innovation, that was Arke Senning's way to go, and he was always able to come up with new things. And of course, quality assessment played a major role. So the title of today is Innovation in Cardiac Surgery and the Need of Quality Assessment, and I will get into that. One thing is for sure, if all these people wouldn't have been innovative and would have taken risks, unknown risk, nothing would have happened in our field, and you all certainly know most of these people, and they made cardiac surgery and cardiology to the standard we have today. Luckily, most of us know many of them. And I think these innovators made that possible what seemed to be impossible. So looking at me, so when I was a young resident, it was a great thing at our farm at home when we got the first telephone. And I had the pencil to learn writing. Time changes, and that's what I'm having now. So I'm completely controlled by electronics, different types of electronics, access to knowledge, imaging, etc. And you are always kind of on call, on email, so you can't prevent that. Is that innovation? Is that a real benefit? Sometimes I think the best thing is we go back to the old telephone and switch all the other things off. Senning, he really was a pioneering cardiovascular surgeon. And you take all these 9 things, pump oxygenator, hypothermia, and cardioplegia, first electric fibrillation, and taking out myxomas, first pacemaker implantation. He implemented the fascia lata tissue valve. He did the first heart transplantation in Switzerland. He promoted coronary bypass surgery in Europe. And he promoted, and I think together with Professor Rüdesheiser, he is the father of Grünzig, and is the one who these are the one who are responsible that PCI has been so successful. You know all his work about the atrial correction of transposition of great arteries. For me, as a young resident who had to assist it to my chief in Bonn, I really had always a hard time to follow because this was so complicated. You had to have these 3-dimensional thinking. And if you are young and you haven't seen that so often, it was hard to understand the pathology at all. But then to switch this around was quite a complicated operation. And he introduced that early on. I mean, he had a first and a second type of the switch operation. And here now it's easy to see that you have this baffle with atrial and septal tissue connecting the venous blood into the pulmonary side, and the pulmonary vein blood will connect it through the right chamber to the aorta. There was another operation as well at the same time by Dr. Mastad, but you can see over the years that there was a change from Mastad, which he was using pericardial or Dacron patches for tunneling and recircling the blood flow. But the advantage of the Senning technique is that it was autologous, well-perfused tissue, and the assumption was if we use that kind of tissue, we won't see shrinking, and we won't see, or we will see less tachyarrhythmias, and we may see also some growth in time. Actually, the latter was really true. There was growth, and there was less shrinking as compared to the Mastad procedure, and that is one of the advantages why in long-term follow-up the Senning procedure more or less was more successful than the Mastad procedure if you look at the term of freedom of re-intervention at 20 years. Meanwhile, of course, transpositions are most often treated by the switch operation, and Senning procedures, atrial switches, are more or less abandoned. Senning, I think he was a excellent, ingenious surgeon. He was a clinician firsthand. He was also a scientist, maybe not the best writer himself, but the best thinker. He was always able, and I do know previous co-workers of him, like Jörg Kugelmeier, who always said, you know, if you walk and work with him, he always has a new idea. And I always made the point he was clearly one of the greatest innovators in cardiac surgery. Now let me focus on my subject, innovation and quality assessment. New technology is always the result of innovation, which is the driving force of progress and is a consequence of research, science, and the cooperation with engineering. Driving force behind innovation are several situations. We have, of course, the interest of patients who are very sick or are even sicker, and all in a sudden there are some patients who couldn't be treated, who can be treated with, with innovation now. You have the surgeon who can all in a sudden develop new technique and treat the patient. We have the departments who want to grow and attract patients. And we have the societies who somehow have to pay for the innovation and have also to control the innovation, whether it is effective or whether the resources are used in the right way or whether they are abused. And one very, not to underestimate, very important factor is industry. Industry is always pushing for innovation in interest of their sales, and that sometimes is more important than quality. At the very end, we have to take care of the quality assessment and to say early enough whether it's good or bad. Of course, if we look at the society and the surgeons, there are also incentives for surgeons and departments. Why should we do innovations? It's the personal career of every single surgeon, the number of publications, the impact factors, they will give you more money from the university. And it is the competitiveness in between the other centers to be the leading center. And maybe also, if you are innovative, you may attract more residents for your discipline. This is a typical innovation curve from industry. You can take that for almost for everything. There is an innovation, and Senning is now the innovation, and he innovates a new technique which is slowly growing, and then you have early adapters, and it is growing even more, and the market is going to adopt this new technique as a standard, and all in a sudden a new innovation occurs. And of course, in this case, I just take CABG and PCI, and the responsibility, it both comes from Zurich. The innovation of PCI being supported and developed over here in Zurich by Grünzig and his mentors, all in a sudden it outgrows the later or the old innovation. And the late adapters are still there doing their bypasses, and they ignore the innovation of the new innovation, which may be a mistake. So if you look into these progresses, this is an ongoing progress. You always have technology innovations in these innovator curves, and one innovation follows the other one. And there is always a crest, and the next innovation starts, and there is a time delay until this is implemented. If you look into this from the business point, there is the innovation curve, and there is a gap in between the business, the technology innovation and the business innovation, because the first step is the technology innovation and then the business innovation, and they then come closer together, and once in a while they will meet and have an integration point. If everything happens right, you have also to develop the infrastructure. It's not only the innovation and the technology innovation, it's not the business innovation, it's also the infrastructure necessary in the hospital. Typical example is TAVI, is also the infrastructure of hybrid rooms, which has adapted to the innovation of catheter-based techniques, and the gap is closed. All in a sudden, everything is together, and you can work it on an excellent way. So there is, for many centers, still a gap in between what's necessary, but there is already, in some centers, the gap is closed. So if you look into your life, and this is the lifespan, it's for years, and you can see in human life there is a rapid development. New technologies came through the years, over the years, and in the last years, it's just in your household, there's such a rapid development of new technologies, and I mean, it's your wife, your kids, or yourself, you bring a new tool home, you don't need it, and you may just use a little bit of it, and then it's there, and you get the second or the third generation, and this is how technology is overwhelming us, and of course, because of sales, innovation, etc., you accept it and go for it. If you compare this to what you really need, the bottom line, this is us, the human being hasn't changed much. So we are simple. If we go to the beach and have a beer, usually we are happy and this is it. We don't need all these tools. And this is the exponential trend of innovation, which is far more than a human being can cope or can use for himself. So this is far ahead for all of us. And the world of technology is going to rule us out with no need for no really evidence-based need. So you can, a very practical example is that if you would have asked 8 years ago, do we need this? Every surgeon would have said, oh, shit, we don't need that. Or why should we need that? We can operate every patient 80 years, no problem. We've done that. I've never rejected a patient with aortic valve stenosis. And all of a sudden, there is a guy who does it catheter-based. And all of a sudden, I just show these. There are even 10 more examples of new innovative technologies and valves who are the next step. The new innovation is taking over. And I will come back to this later. And of course, there are some questions and question marks who need to be answered. If you are applying new technologies as a surgeon or cardiologist, you should always look in the mirror every morning and ask yourself, who am I if I look in the mirror? Am I an innovative surgeon? Do I want to take the extra personal risk? And do I want to put the patient at extra risk because of innovative technique? Or am I a conservative surgeon with low pioneering spirit? I'm a late adapter. I play it safe. I'm just do one IMA instead of double IMA. Or thirdly, am I a high society surgeon? I just do the routine surgery. I get the patients anyway. I buy the technology. I buy a robot to get recognition, but I hardly use it, but I have it. But I take my time for golfing in the afternoon, and then I enjoy my life. So every morning you can make the decision. In general, you make a lifetime decision. There are ethical risks in new technologies. Applying new technology in cardiac surgery or cardiology is the same. You are subjecting patients to unproven technology. So there is unknown risk. On the other hand, if you don't do it, you withhold proven operation, or you withhold proven operation with known excellent results. It's also true. The question always arises, how completely do you inform the patient? Are all possible complications yet defined? Can you really explain everything? And do you want to explain in innovation everything to the patient? He may say no, and you can't do it. Of course, at the very end, incomplete patient understanding is a risk for yourself, because he may come back to you when the innovation fails and say, why didn't you tell me that there is an additional risk? And of course, the new innovations most often have incomplete comparison to proven methods. The other question, again, if you withhold the new technology and you just say, I stay conservatively, is it ethical to deny patients new technology? When a valve can be repaired, is it ethical to replace it? I mean, this is coming up this year when the mitral valve replacement catheter-based is going to start. Many people think mitral valve repair doesn't work. Let's put it in by catheter-based. The functional MR has a bad outcome anyway. Patient desires minimal invasive valve surgery. And you cannot withhold that. You have to answer that to the patient and train yourself or your cooperating partners. You cannot deny that thoracic aortic graft stenting or PCI is there. You just have to select together with your cardiologist the right patients. Is it ethical to put saphenous vein grafts in young patients? Or catheter-based valve implantation in young patients? There are still question marks, as I said. Contemporary cardiac surgery is an evolving field. We see transcatheter aortic valve implantation, mitral valve repair. We do see the minimal invasive mitral valve surgery, arterial grafting, OPCAP, etc. We have this, which is all technology dependent. We have the hybrid rooms and robotics. And new techniques, again, need to lead to developments and to innovations in the field. And if there is no innovation, for sure, there would be a standstill. This is very, very important to remember. This is quite similar to industry. Maybe not just the same, but the thoughts are absolutely comparable. If there is an innovation gap, and I showed you beforehand that there always is an innovation gap, you always have to ask if there still is a gap, because my infrastructure, for example, is not really there. Is it right that I put my patient at risk? So now I come to the problem of quality control. Again, you see down here, this is the actual benefit of the patient, and there is the big gap of innovation which should be possible, but because of different reasons, it is not really possible. So there are 7 pillars of quality control. It's efficacy, it's efficiency, it's optimality, acceptability, legitimacy, equity, and cost. The definition of healthcare quality is defined like that. Quality can be defined as a degree to which the health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So this is, I think, quite understandable. So why do we need increasing quality control? The complexity of surgery is increasing, the comorbidities of the patients is increasing, the age of the patients is increasing. We have an excessive variation in practice, be it in cardiology or in cardiac surgery. The number of new technologies and devices are increasing. We do have better educated patients, even though if the internet education may be not the best. We do have the regulatory pressure through insurance companies, through our administrations, if they, and I will come back to that later, how insurance companies quality control ourselves, and some people just ignore that. And of course, the high and increasing cost of the healthcare system makes quality assessment a must. There are missing concepts and evidence for quality assessment, and there is no general concept on how to assess the quality of new technology. And there is, coming from Zurich, you probably know these articles from General Surgery from Dr. Dindol, quality assessment in surgery, mission impossible, and riding a lame horse, and they developed the Clavian factor. I don't know what you know what the Clavian factor is. All of Zurich should know that. The Clavian factor is 1, 2, 3, 4, 5. So 1 is a complication which may be a little hematoma, doesn't matter. Number 2, it needs an intervention. Number 3, it needs maybe intensive care. Number 4 needs re-intervention. Number 5 is dead. And what he did, or they did, they graded their patient, their quality control in general surgery, and looked around the world to grade. And they asked the residents to do it. And they also asked to look for comorbidities. At the same time, a study nurse did the same study. The interesting fact is that the residents, despite the fact that they had the training how to do it, they only reported 30% of the complications and about 50% of the comorbidities. The study nurses did much better. And after re-education, the same thing happened again. So what are the reasons for that? They argue in the article, and I recommend it to read it. The working time hours in Zurich are only 50 hours, and there is no incentive to do it. If you do it or don't do it, it doesn't help too much in your career, etc., etc. At the very end, it's all over Europe sent out, and it was interesting that the academic centers responded to their questionnaire, and the non-academic centers did not respond. And this is true also if we look in our own quality control, that one has to have a professional infrastructure if you really want to have quality assessment. And it shouldn't be the resident, it should be not study nurses and somebody who guides them. The essential elements for quality assessment have been defined by law in 1990. You have to have an appropriate service in a technically competent manner, so that's the infrastructure I just meant. You have to have effective communication in between nurses, doctors, and the study nurses. You have to have shared decision-making, and you have to have the cultural sensitivity that you accept that you have complications, and yet you analyze it, and you are ready to do something about it, not just to hear it, but you have to change something. Who should be addressed? All practitioners, the patients, and the general community. Avedis Donabedian, he has defined a model for healthcare quality assessment, and I will show you the 3 major types of quality which need to be controlled. Number 1 is the structure, which includes the trained personnel, your recording system, your finances, supplies, and your facilities you have. The process, what means that all the activities, the training, and the way you work are well-trained and well-controlled. And at the very end, you need the outcome control. And of course, you need different levels, and we'll get into that in a minute. You have to do that on a national or organizational basis because health policy formulation of infrastructure and performance and monitoring needs micromanagement for the whole country. You have to have your control in your institution and your department. And at the very end, you have to control every surgeon. So this is this matrix. Question mark, question mark, question mark. Everybody of you has to fill out this matrix now and to define how he fulfills it. So if you look into his, adapted to his model, the structure, the process, and the outcomes, it's all interconnected. You have the specialized centers, you have the special providers, you have accessible services. The process has to be high quality. The outcome has to be safe, cost-effective, and the individual mortality and morbidity has to be controlled. First, structure. If you talk about structure, specialized centers in cardiac surgery, you have to define it. And on community part side and on departments, you have basic standard guidelines. You have to have studies and meta-analysis for controlling the results, specialty centers, and reference numbers. So we from our German society have defined recently, after Hans Borst in 1968 had defined the structure of cardiac surgery at the time of 1968, how a department of cardiac surgery should be structured, what should be the minimum capacity, and what are the reference numbers they should refer you. This article was published in 2013 in the Thoracic and Cardiovascular Surgeon. Maybe it's of interest of your society. I think Professor Giannoni knows the article very well. So there are some analyses around the world who have looked into structure and volume and outcome. And this is from the New England Journal from 2002, and they looked at 2,500 million procedures, cardiovascular or cancer. And if you look into their analysis, coronary bypass grafting, aortic valve replacement, mitral valve replacement, and always look how many cases do they perform per year, it is quite evident that the patients do better and can significantly reduce their risk of operative death by selecting a high-volume center. Another analysis, this is a meta-analysis comparing PCI and CABG, so it's not only true for coronary bypass surgery. I can see Thomas Löscher here, you should pay attention now, because it's also very important for PCI. The effect of center volume in hospital mortality after PCI in the meta-analysis is also very evident and favors high volume versus low volume. Same is true for coronary bypass surgery. In general, it means patients undergoing CABG or PCI in high volume hospitals exhibit lower in-hospital mortalities than those treated at low volume centers. There is an analysis from the STS database published in 2011, and generally it says, okay, we have higher risk patients, we have more patients, but our mortalities are going down and are better, so it can't be too bad. If you divide that, and that's what they have done into these cardiac procedures, coronary artery bypass, aortic valve, and mitral valve replacement, again you see the effect of those centers from 2000 to 2009 who had the impact on the lower mortality. It was the high volume centers in the US who had a much lower mortality. And they claim the strong inverse relationship between hospital volume and mortality persists in the modern era. We also know that from the United Kingdom with the congenital cardiac services, and you do know their constitution, that they have restructured the whole organization and the situation where congenital heart disease has to be performed. Now I go in further detail. I think it's extremely important that you control your own performance as a surgeon and this is an analysis from our own center, altogether 17 surgeons who participated in minimal invasive mitral valve surgery, and we published that last year in mitral valve surgery. In general, you can say, if you go through all severe complications, mortality, conversion to sternotomy, re-exploration of bleeding, cardiac reoperation within the hospital, and stroke rate, in general, the more you do, the more or the lower the complication rate is. We also have evaluated learning curves. So I can confess I was a beginner early on, and it took me about 100 cases. If you stay in the dotted line, you are still in the normal range, but you want to outperform, you want to be excellent. So you need to be, I needed about 150 cases to learn this new technology and to outperform what would be expected in this. CUSUM analysis means cumulative failure analysis of the operations. If you take surgeon number 6, it was a German surgeon who works in Switzerland right now, and he was trained with myself, and he was introducing the technology early on, and he had learned from all my mistakes. So his learning curve was much shorter. So he just needed 100 cases. And then we had surgeon number 16. Very recently, after 100 cases, he had too many complications, and we pulled him back, we retrained him. He had to operate with one of the experienced guys because he was underperforming and had to start on a new level. We have done the same for midcap. This is an analysis of 1,400 midcaps, also published already in 2007. And again, you see the magic number of 100, 150 of operators where the failure rates go down and stay down. And again, the analysis of surgeons with little experience, intermediate experience, and you see these two down here. This is my previous colleague Arno Diegler and myself with large experience in midcap. How it matters how often and well trained you are when you perform. So this is process. Technical skills, interpersonal training, inpatient and outpatient. What is important that you qualify special skills and like congenital heart disease, pacemakers, and transplantation by the German Society. We have these 3 certificates, and we are on our way right now to develop the certificate for catheter-based intervention on valvular heart disease, where the surgeons have to go through a cath lab training, and otherwise the cardiologists have to go to some surgical training. And we think that a person who has been fully board certified can, after 2 years, apply for such interdisciplinary certificate. So now outcomes. There are society reports, there are disciplinary reports, and there are, of course, interdisciplinary registries and randomized controlled trials, which are important. This is our annual report in Germany from 2012 to 2013 is already published. It's a deliberate registry which exists for 20 years where all cardiac interventions are deliberately reported to the German Society, and we always develop an extract and write a report about the years, and you can say how many procedures are performed and how the mortality is, and you can define how many cases have been done in that number of institutions, how big the institutions are, etc. We also know if we define, this is anonymous, we also know which, in an anonymous way, what is the mortality of the given center, but we don't publish that. Again, the development of Cardiac surgery in general, it's going down a little bit. Only the catheter-based situation has rescued us, and we see the same thing as we have seen in America over the years, that despite the higher complex cases, mortality is going down. Unfortunately, in looking at OPCAP and on-pump surgery, there is no increase. So the enthusiasm is there in some centers. Some centers are up to 100% and do total arterial grafting, and some just don't do it. And the recent literature doesn't support actually to do it this or that way. In general, you can do, if you want to do off-pump, you have to be very good to completely revascularize. That's what we can say. You can see the development of TAVI, and this 6,400 is still underestimating because we are missing 2,500 patients being done outside of cardiac centers with cardiologists and with assistance of surgeons who are not reported in our annual report, but they are reported by the AQUA Institute. So we knew 2012 we had about 9,000 TAVI. I said at the beginning, if we don't do the quality control ourselves, others will do it. And we have the same, if you look at this annual report here, it defines risk-adjusted the outcome of coronary bypass surgery in the different hospitals, and it is divided by the volume of the hospital. And this analysis is in internet. It's done by the insurance companies, and they take it out of the official report of the AQUA Institute, and they can and do identify every given center. So it clearly shows that the outcome in most of the centers who do almost 800 to 1,000 cases besides two is less than 3%. There are also some centers who do small case numbers having good outcomes, but in general, they question you, why do the other centers have an approximate mortality of 5%, where the average should be 3%? And they know exactly which hospital is which. So we have to be prepared that everything is public. Finally, I just draw your attention to our German aortic valve registry, which we have founded together with the German Society of Cardiology, starting in 2010. And now we have 98 centers participating, and until May we had 67,500 patients who are consented to participate. So this registry controls all aortic interventions, both surgical or catheter-based interventions, and we want to see with a 5-year follow-up, which is done by an independent institute, the Bundesgeschäftsstelle für Qualitätssicherung, who do the follow-up, and we are just analyzing the data. These were the 1-year data, and you can see here, if we divide, it's an analysis of about 13,600 patients that transapical, the upper blue line, has the highest 1-year mortality. Then comes the transvascular femoral, then the aortic valve plus CABG, and very low, the surgical aortic valve. And of course, there is this difference. If you divide all these patients in between younger and older than 75, you still see the same situation, that the surgical patients in the cohort are have a very good 1-year outcome, and still the transapical are the worst. If you then divide, and we did the division in between Euroscores, in between the group, you see in the high Euroscores group that the transfemoral is the same result, and even in the 20 to 30 Euroscore, the transfemoral comes close to surgery, whereas in the other intermediate and low scores, surgery clearly shows a better 1-year outcome. We have a special score developed through the years for the early outcome, which is the German aortic valve score, and we also divided the patients in these different scores. And again, you can see that conventional surgery still has a place, has a real good outcome in the first three groups, whereas in the AV score more than transfemoral and transfemoral does as good, maybe better than the surgical situation. We will see very soon at ESC the results from 2013 as well, and have a better income. We know very well that if patients have aortic regurgitation, they have a higher mortality. So now I come to the end of my talk. In summary, quality assessment. There are structural, process, and outcome. That's what I defined. And you have the individual situation with training, reference numbers, and studies. You have the department structures. You have the specialty centers, which you have to have, in my eyes. Not everybody should do the mitral valve repair because if he only does 10, it is very, very likely that 10 in a year is not good enough to be an expert. And the organizations have the guidelines, the meta-analysis. And the organizations also have educational processes like the EICTS and ESC courses and academies. In individual situations, it's very important, the trainings, the certificates, and a continuous individual analysis. So every surgeon, every year in our hospital has that CUSUM control analysis, and by the end of the year, we compare the results in between each other. Quality assessment is needed, clear statement, and I'm pretty sure innovators are needed. We would contend that it is mandatory for all surgeons to understand and probably apply quality tools so that we can police our own practice before others will do, such as the insurance companies and hospital administrators will do it for us. And I showed you that example, and this is a quote from Dr. Dindo and Klavian in Surgery 2010. I think it's time to play. Everything can happen. Well, it wasn't too bad. Huh? I close with the remark of Orke Senning after his first transplant. One must merely sow, and when one knows where to sow, there is no problem. One must merely be wakeful, and when one knows how to be wakeful, there is no problem. Thank you very much to have the chance to give this talk.
Thank you very much for this beautiful presentation. We really enjoyed this. It's a great point made, the importance of the training, importance of the volume, and all these things I think we'll keep in mind in order to be better in the future for our patients. Thank you again for your participation. Thank you. This is honorary membership for our society, because we really appreciated your contribution to cardiac surgery, and especially for us.
Thank you very much. I feel very honored, and thank you, society, to be an honorary member.